Hello, and welcome to this video about ERAS updates. I am Carlos Sandoval Herrera, MD. Before we begin, I want to state that I have no financial disclosures. ERAS, or Enhanced Recovery After Surgery, is a patient-centered, multidisciplinary approach to surgical care. It's not just about Tylenol and early ambulation. It integrates metabolic, anti-inflammatory, surgical, and engineering principles. It has been almost 10 years since we started these Sinai quality initiatives for both COE-MIG and ERAs. In the last decade, we have decreased the length of stay, dramatically decreased morphine equivalents, and saved millions of dollars for the hospital. We have also become pioneers with our pre-admission pathway and ERAS RN coordinator. The ERAS pathways cover the entire surgical journey, including pre-admission, preoperative, intraoperative, and postoperative phases. The philosophy is to plan, prepare, and perform effectively. Let's focus on the pre-admission pathway, which is the first step in optimizing patient care before surgery. The pre-admission pathway heavily relies on phone calls for patient education, covering protocol instructions, wound care, side effect reduction, DVT assessment, and clearances. It also includes final instructions, emergency contact, and setting expectations for early recovery. This pathway has improved patient and MD satisfaction. It reduces clinic time for counseling and provides timely reminders. It also coordinates services like prehabilitation and transportation. Marisol Sandoval is our dedicated ERAS RN coordinator. Next, we move to the preoperative pathway, which focuses on preparing the patient immediately before the surgery. Prehabilitation includes nutrition, managing comorbidities, weight loss, high-protein diet, and smoking cessation. Education covers pain management strategies. We also set up post-operative follow-up appointments before the patient leaves pre-op. Regarding preoperative fluids, gastric volume is small, but capacity is up to 4 liters. Sips of water should be less than 50 milliliters. Maltodextrin takes about 2 hours to clear. Clear fluids include black coffee and apple juice, but orange juice is not considered a clear fluid. Maltodextrin, 50 to 100 grams, 3 hours before surgery decreases insulin resistance, maintains muscle glycogen, and slows catabolism. The multimodal preoperative pathway includes preemptive analgesia, with medications like Celebrex 400 milligrams and Tylenol 1000 milligrams. These are given the night before around 8 p.m. to manage inflammation and pain. Gabapentin 600 milligrams is a neuromodulator used to avoid central sensitization. Patients should be counseled on blurry vision and sedation. Pyridium 200 milligrams is used to properly stain the urine. Scopolamine and dexamethasone are other useful preoperative medications. We avoid bowel preps. Why not just use a narcotic before surgery? Narcotics lack blockage of PGE2 and do not prevent edema. They also worsen ileus and nausea. Opioids activate mu receptors, decreasing peristalsis and increasing the risk of aspiration. Tissue injury causes a release of inflammatory markers such as IL-1, IL-6, and TNF-alpha. This leads to a cytokine storm, impacting the brainstem, causing nausea, pain, and ileus. Dexamethasone can decrease neuroinflammation and surgical stress response. Nausea, vomiting, and ileus are connected to enterochromaffin cells releasing serotonin, which stimulates 5-HT3 receptors, leading to a vagal storm. Receptors on the gut vagal afferents and the chemoreceptor trigger zone are involved, contributing to a serotonin storm. Dysuria can result from bladder irritation, catheter pain, and burning. Phenazopyridine concentrates in the urine and inhibits C-afferent fibers, helping to break the loop that causes pain and pelvic floor spasm. 10 to 20% of hysterectomy pain is bladder-related, not incisional. The preoperative pathway is about surgical neuroendocrine perfection to set the patient up for success. We must avoid surgical sickness mode for our patients. In summary, the pre-op ERAS pathway uses Celebrex for peripheral inflammation, gabapentin for central windup, pyridium for NAV1 and PGE2 inhibition, and dexamethasone for the cytokine storm. Tylenol manages central pain amplification, ondansetron addresses the gut-brain nausea loop, and maltodextrin minimizes metabolic stress. SODF, sustained opioid-free delivery. Now let's explore the intraoperative pathway. The intraoperative phase is key to minimizing surgical stress. Anesthesia is equivalent to running 5K. We must counteract enemies like peritoneal ischemia, visceral traction, hypercapnia, and hypothermia, which cause sympathetic activation and cytokine release. Intraoperatively, we focus on aggressive normothermia with the Bayer Hugger, warm IV fluids, and warm blankets. We use a zero-balance fluid strategy, avoiding routine high volumes, as excess fluid can cause intestinal edema, ileus, and other complications. 1 liter of 0.9% NS contains 9 grams of sodium. The 2023 intraoperative pathway highlights the crucial use of local anesthetics like bupivacaine or Marcaine. These amide anesthetics block sodium channels, act as a neuroinflammatory modulator, block visceral afferents, and prevent central hyperalgesia. Intraperitoneal local anesthetic, or IPLA, uses 70 to 100 milligrams to reduce visceral pain and suppress peritoneal inflammation, preventing ileus and opioid use. TAP, or transversus abdominis plain block, is the better technique. Minimizing visceral traction is crucial to minimize pain pathways. The intraoperative pathway emphasizes low trauma surgery to reduce IL-6 release. Techniques include avascular dissection, hydrodissection, precise vascular sealing, and avoiding burning the peritoneum. Using a low-pressure pneumoperitoneum of 8 to 10 millimeters Hg reduces hypercapnia, splanchnic ischemia, nausea, and referred pain. In anesthesia, propofol and TIVA block the master switch of inflammation, NF-κB, and suppress IL-6, IL-1B, and TNF-alpha. This reduces neuroinflammation, blood-brain barrier disruption, and is associated with less delirium and nausea. Ketamine blocks NMDA receptors, which decreases microglial activation and protects against delirium and postoperative brain fog. TIVA offers a 50 to 70% reduction in postoperative nausea and vomiting, PONV. Dexmedetomidine, an alpha-2 agonist, turns off the sympathetic system, decreases norepinephrine and anxiety, and reduces cortisol, which ultimately decreases IL-6 and delirium. However, sevoflurane, an inhaled anesthetic, increases gut inflammation, decreases intestinal motility, and increases the risk of postoperative ileus by amplifying neuroinflammation through NF-κB and microglial activation. There is a clear tug-of-war effect between propofol, dexmedetomidine, and ketamine, which are anti-inflammatory, and sevoflurane, which promotes inflammation, nausea, and gut dysfunction. Don't forget to perform pulmonary recruitment maneuvers to decrease shoulder pain caused by the presence of carbon dioxide under the diaphragm. ERAS-style anesthesia converts surgery from a major cytokine storm into a controlled inflammatory response, protecting the brain, the gut, and the immune system. Now let's proceed to the postoperative pathway. The goal is to maintain a controlled anti-inflammatory state and promote rapid recovery. For the first 24 hours, the pain regimen includes ketorolac, gabapentin, acetaminophen, and phenazopyridine. We also include simethicone and Miralax for bowel management. We use a goal-directed IV fluid approach and assisted ambulation. After the first 24 hours, the pain regimen switches to ibuprofen, acetaminophen, gabapentin, and phenazopyridine, maintaining the multimodal approach alongside the bowel regimen. The prescriptions to go home include ibuprofen, acetaminophen, gabapentin, phenazopyridine, simethicone, and Miralax. Remember to manage the timing of the medications, like 7 a.m., 2 p.m., and 9 p.m., to ensure continuous pain control.